and try to even sometimes throughout the mornings get our breakouts. And this year, obviously, just not conducive for us to be able to get together and get closer and work on each other and try things and stuff like that. So we tried to think through some new stuff that we could go through that you can take home, you can use on your athletes tomorrow, but you're still utilizing that same hands-on, that same manual, that same kind of understanding there. So our first speaker with regard to sacroiliac dysfunction is Dr. Sean Scott. Dr. Scott is a chiropractor from Kingsland, Texas. He was here last year, did a cervical evaluation talk with us. Is our full-on chiropractic consultant for Justin Sports Medicine, works with multiple high schools and their sports medicine groups, and realistically for the athletic trainer is probably our best friend, as he serves on multiple committees and groups when it comes to, I guess, a expert witness or expert in the role of chiropractic and things of that sort, where he can give opinions when there's a lawsuit of things that have happened from a chiropractor. And he is the guy that I will tell you will talk on those issues that we have with chiropractic and things like that. So before we start on an SI dysfunction talk, I will tell you, if you ever have a question or if you ever have a way to like, hey, I need to know, because he understands what we do in the athletic training world, and he works with us on a daily basis as well. Ask him, reach out to him. As busy as he is, he'll always get back with you and kind of like, this is how you can approach that, or this is what maybe we can help and get that continuity of care between the professions and things like that. So, other than that, Dr. Scott.
Man, I had to look around. I didn't know who he was talking about there at first, so thanks, Sean. That's really good. And like Sean was saying, I really understand a lot more than y'all think. One thing that I ask as a DC, I get asked to do a lot of talks, and sometimes that immediate DC eyes kind of fog over. Oh no, here we go, we have another one. So I just want to bear with me, kind of keep an open mind. I'm going to talk about some things with spine and hip that might make you think a little bit, which is my goal. And like Sean was saying, if you all have questions, I get hit up with more questions about the stupid things my profession does. I'll be glad to help you guys out, because that's one of the things that drives me, is to not necessarily improve my profession, but improve the relationships of our group. So as we get going here, I'll stick around afterwards for questions, and hopefully we can get through this. Objectives. Pretty straightforward. I'm not going to go into a lot of detail, but a lot of times when I do talks, I like to do workouts in the morning. And Sean and I decided to do a little workout this morning. We were doing little heavy squats. We were trying to kind of get pumped up for this seminar, and I had these really cool new shoes. I wanted to kind of try them on and see how it went. So, am I not talking loud enough?
No, we're trying to adjust the screen so that they can see you, so that they can see your beautiful face.
Got it. These are a couple books that I reference a lot, and I did bring them. If y'all don't have Starkey's book, highly recommend it. Keep this thing handy. Obviously, I even reference it whether I do a talk or something. Highly recommend it. As far as fun stuff, Dr. McGill, highly recommend getting this book. This gentleman, he's a PhD out of Canada. A lot of stuff that I reference on the spine comes from him. It is more cutting edge. It's not what we're taught. So we will address a few things in the spine. A couple are the books that I usually, I just kind of threw these in. And I believe y'all will get copies of this, so everybody should. And if you don't have a Netter book, highly recommend it. SI joint pain. A lot of you may understand, maybe you don't understand, basically what the spine sits on. The thing we have to understand about the joint is it's a shock absorber along with the spine. But the SI joints do have a lot of movement. We think that they probably have more than they actually do, but they don't. And so you'll hear a lot of times, we've got to free up the SI. There's not a whole lot to free up, folks. I'm going to tell you that. This is something I do every single day, almost 7 days a week, is SI issues. The causes, most of you are here, you're going to see them with sports injuries. They can be from repetitive injuries. The reason I put anatomical short leg on here is, I'm not talking about the silly chiropractor that says you have a short leg. I'm talking about true, measured, anatomical shortness. If you have an anatomical short leg, which you will in your athletes, especially if you start checking them, they're going to have SI dysfunction on the short side. I can almost promise you that. So that's why I threw the scoliosis. Obviously, that's going to cause a rotation. And the SI joint is going to try to lock down to try to stop the curvature from happening. Don't want your kids to have spine surgery. It's going to happen. So threw that in there. Pregnancy. Additional symptoms. Basically, your SI, standing up, sitting down, that's when your athletes are going to notice it. The biggest thing I want to get across today, as far as the SI goes, is it's the great imitator. The problem is it'll act like a disc problem. It'll act like a nerve problem. It'll act like basic musculoskeletal strain injury. And so a lot of you are probably going, oh, great, how do we figure that out? I think we have to understand what the spine plays, what the pelvis plays, and then we can understand the SI. And the problem too is, even from a nerve standpoint, it will mimic a herniated disc, and you don't have a herniated disc. And we'll walk through that. When you're looking at the SI, just remember they're at 45-degree angles. When you're trying to motion or feel or move, it has a real funny articulation. And until you get used to, every time I do a talk and every time I do hands-on, I tell people, you have to know what normal is to know what abnormal is. And Sean's heard me say that 100 times. If you don't know what normal is, you're going to fail at abnormal. Because what if your athlete or what if your person has bilateral SI dysfunction? Then it's going to feel normal. So that's why we have to do that. The referral pattern of the SI can mostly be in the glutes, 94%. But what's interesting is 72% of the time it's in the low back. So your athlete's going to come to you and say, Coach, my back hurts. Could be SI. It's just something we need to think about. They can also have groin pain. So you're going to have these random groin, well, what did you do? I don't know, my groin just started hurting. So we kind of have to think outside the box. Instead of our groin, maybe something else is going on. They can even have lower abdomen pain. You might be thinking core injury. You might be thinking abdominal. It could be SI referral. So I threw these on there in percentages because I wanted you guys to really understand most of your pain is going to be low back or pelvis. The thing, can we start? Because I want to show the, just for a second, just on the slide. Okay, perfect. One thing on the chain chart, and I really like this, is whenever I'm talking to people, I tell people we need to stay away from the neck, we need to stay away from the low back as far as the treatment. Everybody wants to treat the neck and the low back, but we really need to be treating the thoracic spine and the pelvis. And the reason is you want your mobility factor to be in the thoracic spine and in the pelvis, more importantly, the hips. Your lumbar spine and your cervical spine are stability structures. If my neck is not strong, my head falls forward. So therefore, it's a stability structure. Otherwise, we're a bobblehead. If the lumbar spine is not a stable structure, we are going to have a lot of problems in the lumbar spine. So the pelvis has to act as a support system. The hips are where you're mobile at. Your knees have to act as your stability. Your knees have to act as your stability. Your ankles must be mobile. And I'm going to pause here for a second because as we go through these next slides, I want you guys to think about when we are taping our ankles for our athletes, what are we doing? And I don't want to create a lot of controversy, but if the ankle is meant to be mobile, and we're immobilizing it, what are we doing to the spine? 100 years ago, our posterior chain was fantastic. This is how people rode horses. Didn't matter what segment. Our hinge movements were a lot better. Even working outside, that's pretty good to me. Even our students, upright, good, great posture. Then the advent of the automobile, everything starts changing. This is our kids now, not very good. This is what we're doing in the classroom. It's what y'all are even doing right now. So then we tell them, let's exercise. Let's go get on a bike. Let's flex for 6 hours and ride a bike. No, let's row. Sean, let's row, right? Let's flex the spine and let's row. Let's sit on the sidelines as we're waiting to get in. Let's flex over. No, let's do some more aggressive movements. Let's get more active. All these people are going to start developing SI pain. So when you get your athlete that comes in, looks like a simple hip contusion, and it might be. Sometimes it is what it is. If it looks like a duck, sounds like a duck, it might be a duck. But don't forget that simple injuries that you're going to see every single day, there may be additional, especially when your athlete is not responding, or you just have that gut, something doesn't feel right, or they're not presenting like a normal injury. We have our basketball people fall into the ground. We have our gymnasts, our volleyball people. This is kind of a great imitator. It's going to mimic a lot of other conditions associated. And those of you that do rodeo athletes, you're going to see a lot of pelvic and SI issues. And you can kind of see by a couple of these pictures. They're going to come in with SI pain. The reason I brought this picture up here, so we've got Baker running down the field. I'm going to kind of go over here. And I want you to notice his ankles obviously are taped. His knee to me looks like we've got a little bit of a varus issue. He's got a valgus issue on his right knee. His pelvis doesn't look too bad. His shoulders look pretty straightforward. So going back to our chain, if we're taking the ankle mobility away, are we putting more stress in the knees? And are we taking away more movement out of the hips? So if we looked at the athlete chasing him, we've got pretty good ankle movement. We've got great knee stability. Hips look like they're working good. His actual movement is in his upper back, which is what we want. So it's interesting, you've got your defensive lineman chasing Baker. If we look at Ezekiel, kind of same thing. His ankle looks like it wants to evert, it wants to push off. Got a lot of knee pressure from this movement. Look at the right knee. Hips are kind of rotating. He's got a lot of SI strain going on. And one thing when I was at Lake Travis, I learned a lot being at a real high level school, working with their strength and conditioning people. My first probably week on the job, I had 2 disc herniations. The second week, I had 2 more. Within a month, I had 6 kids with herniated discs. I thought, holy cow, Hank's going to run me off. And it kind of got me thinking a lot about what are we doing with our football athletes. If we look at our track athletes, let's look at the fastest guy. Look at his ankle, great mobility. Knee looks stable, hip flexion looks great, pelvis looks good. That's what we want right there. If we look at the side view, everything's looking good. And you can see the difference in running of your track athletes from your football guys. But they're still going to come to you with this kind of great imitator, the SI pain. And so what do? We tell them, stretch. No, let's do buddy stretch. Let's get a really big guy and push down and do more stretching. Oh no, let's get our kids stretching, because if we stretch them when they're young, we're going to keep them from having problems later. Let's give them a band and have them flex forward and stretch. No, let's have them really stretch. And so now we're going to start developing spine issues. Remember, our lumbar spine is meant to be a stable function. Yes, there is movement in lumbar spine, but it's meant to be stable. And I'm going to be honest with you guys, lumbar spine stuff is tough. I mean, I make a living doing this. I see crazy stuff all day long. I get calls on crazy stuff. It can be really tricky. And I know, talking with so many athletic trainers over the last 20 years, one of the biggest things I get told is, and I'm going to be delicate here, maybe the lack of spine training or the lack of spine work. And I understand, and I work with so many people, and they'll come to me and go, oh, there's a hamstring injury, a groin injury, a pelvic injury. And so I want you guys to kind of start thinking a little bit different. Let's try to summarize a little bit to give you guys a little clarity on the lumbar spine. Because if we understand the lumbar spine, if we understand the pelvis, we're going to be able to understand and treat the SI joint. Your lumbar strains are pretty straightforward. If you move the muscle, it should hurt. It doesn't matter where you move it, it should hurt. So if you have pain in all directions of the area that they're complaining, pretty straightforward, it should be a muscle strain. If you do not have pain in a movement of the muscle, it's less likely that it's strained. So just remember that. Facet dysfunction is primarily with extension. There are other conditions with extension, but I want you guys to kind of, we have to have guidelines, and then we can get more specific. Low back fractures. I'm going to get into a couple ways to test on the field, on the site, real quick things that I do all the time, and they have really saved my butt. Herniated disc. If your spine is moved into flexion, you should recreate pain. You can have lateral flexion with disc problems. So flexion and lateral flexion, so keyword is flexion. So a flexion movement should recreate disc pain. Just guidelines, people, let's just keep it simple. So movement of the muscle, strain, movement and flexion, disc, movement, extension, facet. There are spondies or other things, we'll get into that in a minute. Just a little picture to kind of summarize what I'm saying. Something that Dr. McGill talks about is, what are we doing to our athletes when we have them do therapy first thing in the morning? We know what happens. Your athlete gets out of bed, they get their Pop-Tart, they drive to school, mom and dad drives them to school, they're half awake, they come in there, they're grouchy, they don't want to be there. What do? We start working on them. We start putting them through full flexion maneuvers. Or we send them to the gym, or they're doing their workouts. And those of you that are not comfortable in the squat world, I highly recommend you to really learn. You don't have to be a strength coach per se to want to know more. Talk to Sean. He's really, really good at a lot of this stuff. What I found at Lake Travis was, this was a lot of our problem right here. When we started making changes, we didn't have any issues the rest of the season. And it came from open coaches, me presenting things in a non-threatening way, and creating a great trusting relationship so that we could make subtle changes with the bar, and then as we loaded our athletes, we were able to reduce. I'm not saying you're ever going to eliminate, but you're hopefully going to reduce. Something that Dr. McGill brings up a lot is the deformable vertebra theory. And I don't normally ask a lot of input, and you're not going to hurt my feelings by not raising your heads, but give me a show of hands. The disc material is the shock absorber of the spine. Would you say that's correct, not correct? Pretty quiet group. That's good. I was pretty quiet too. We have to remember that the vertebral body is the shock absorber of the spine, not the disc. So if you've been taught that the disc material absorbs the material, that is incorrect. The reason the vertebral body is not solid is because when we load our athletes and the disc material actually squirts into the vertebral body like a sponge, that becomes your shock absorber. So the disc material Sole function is to put the material into the vertebral body to allow us to absorb the impact, whatever it is. Whether we're squatting, jumping, running, twist, fall, whatever. And I just kind of broke this down here. When the disc material exerts too quickly or too aggressively through the end plate, we develop what we call a Schmorl's node. Everybody, that is an end plate fracture. And I want you guys to start requesting radiology reports from your spine athletes. And look, and you're going to see the word Schmorl's node a bunch of times on your reports. And you're going to ask your athlete, so what's wrong with your back? I don't know, they just said extremely. You're going to read the report, and you're going to have a Schmorl's node. Comment on it. Schmorl's node of L3, end plate, whatever. That is an end plate fracture. And we know what happens when bones fracture. The only way it can heal is if they lay more calcium down. So I have an end plate fracture on my athlete. We know more bone is going to be laid down. Now, you have a permeable end plate that is designed for the disc material to reabsorb and fluid to go into the body. Now I put more bone over there, and I'm going to stop the disc material from going into the vertebral body to act as a shock absorber. What do you think is going to happen? And this is just more writing for those of you that like to read. And one thing before I show you the next slide is end plate fractures cannot handle upright activity. Your athlete will come in, they might be bent over, and you'll say stand up, and they're going to drop. A disc herniation, you can stand up. As soon as you flex them, they're going to go down. End plate fractures cannot stand the axial load of just being upright. So it's a huge indicator that you have a fracture in the spine and they need some kind of attention. Now, these are non-surgical conditions most of the time. And you're going to have a lot of, my back is fine, you'll get the report, because I get them all the time. And it'll say, multiple Schmorl's nodes at blah, blah, blah. This is what they look like on an x-ray. You see the thickening of the end plates. So now the disc material cannot get into the vertebral body. So we've completely changed the function of the spine now. And this can happen even in some of your young athletes with repetitive trauma. You know, we're starting our rodeo athletes at 4 years old on mutton busted. You know, our football kids, pee-wee football, they're going to show up in high school with spines like this. And unfortunately, you're going to herniate a disc. Because when the disc material cannot get into the vertebral body, the only way it can go is backwards. This is actually one of my athletes, defensive lineman. He came to me, they were deadlifting. He just had simple low back pain. He didn't have any neurologic, was great. Only thing that bothered him was, as soon as he got here, he got a lot of pain. I sent him for an immediate MRI, I was suspicious of a disc. Sure enough, he had a central disc herniation. Just want to touch on a little pearl. Central disc herniations are very common in your young athletes. You're not going to see neurologic, meaning radiating or radicular symptoms in your young athletes because the disc space is such in good shape. So when we tell people, oh, it can't be a herniated disc because there's no leg pain, that is so incorrect. I would say the majority of my young athletes never had leg pain. But I'm going to tell you, if you have an athlete that has a disc problem and they have leg symptoms, we have potentially a really big problem. And you need to take that very, very serious. Central disc will not touch the nerve roots, therefore will not give you nerve pain. But they will give excruciating pain with flexion. But remember, end plate fractures when you stand up, you'll have pain. Disc herniations when you stand up, you'll be no pain until you flex. Another picture, kind of same thing.
John? Yes. On those x-rays, if you got one of you show everybody exactly what you're talking about?
Can I go backwards?
I will point.
Do I?
I will point.
Okay. Is this one, Robert?
Yeah, start with that one, go back down so everybody knows what you're pointing at.
And say your question again.
Where that, FD fracture is.
Okay.
Easy.
They can't see it from there. It
I got you.
doesn't show up on our screen here.
Yep. Put it right below that. No. Put it right below that line. That white line. There, Sean.
Sorry. Look, there it is.
So here's the beginning of one, and then if you'll go up to this one, right above it, or even
Mouse doesn't like to come back.
go up. That right there, that divot is a Schmorl's node. That's an end plate fracture right there. Here's another one at L5. You'll drop down. Drop down, drop down. And actually the superior and inferior end plates are. So the question was, is can you show us an actual picture, put the arrow on the end plate or Schmorl's node? And that's what we're kind of defining. This is a really good picture of an x-ray because it shows multiple Schmorl's nodes. This is what they'll look like on an x-ray, and I tell you, you're going to get normal x-rays. There's nothing wrong. Orthopedically, you'll get them all the time. Oh yeah, kid's fine. And this is what they're going to look like. Not to this severe. When you have a young athlete, a 16-year-old, and you get a Schmorl, it's calcified. So you're only going to see just a little divot. Another x-ray. Can we go?
Yeah, here we go. We got a deal going on. Okay. That was the last name. That's right.
That's it, okay. Sorry for the little pause here. Focus. Abracadabra. Okay. This is what's going to happen to your athlete. Everybody's going to blow that disc out. So if the disc material has nowhere to go, it can only go out. I like to show this picture of Tiger because, and I don't know what level of, if this was before his first, second, third surgery. I don't have an answer on that. But I can bet you his x-rays have multiple Schmorl's nodes, multiple end plate calcification, healing, and the disc material has nowhere to go. The force that he does on we know this is Sunday because that's his red attire. This is what happens right here. And if we're not careful, they'll end up in a fusion after multiple, which is exactly what happened in Tiger. I'm going to kind of go through here. We're going to talk about the posterior elements of the spine. I'm not going to go through a ton of anatomy.